بسم الله الرحمن الرحيم. معكم طالب نواف صلاح من جامعة المعرفة. واليوم النهاردة هنراجع مع بعض ال COPD أو الاسم الكامل ال Chronic Obstructive Pulmonary Disease. طيب, so for the purpose of this disease, I've got a couple of resources from AMBUS as well as from جامعة القرعة for the SMLE, and parts of it from previous lectures from the curriculum of جامعة المعرفة. Regardless of the resources, the main goal of revising the COPD is for the purpose of the SMLE, okay? So as quick revision for the COPD, let's revise. What is COPD defined as? It's defined as an obstructive lung disease, alright? So it's an obstructive lung disease, and we'll come into as to why that occurs. What is the lung pattern? Well, the lung pattern is obstructive in nature, so it joins with bronchiectasis. It joins with asthma, and it also joins with chronic bronchitis as one of the many obstructive lung diseases. And it's a chronic condition. And finally, the pulmonary function tests, which show that the ratio of FEV1, which is forced expiratory volume in 1 second, / forced vital capacity FVC. So the FEV1 / FVC ratio would be less than 70% or 0.70, which is suggestive of obstructive lung disease, which is caused by a combination of small airway obstruction as well as parenchymal destruction or lung tissue destruction. So this is just a quick revision of COPD. Of course, it's characterized by respiratory symptoms. Now, one thing we should keep in mind is COPD most commonly occurs in males who are in their 40s, so middle-aged males. So in any case with COPD, it will show a male in his mid-40s who's typically a chain smoker, all right? And we'll look into the cases in the next video. Of course, the risk factors for COPD, they're endogenous and exogenous causes. Of course, the most important and the most common risk factor for COPD is smoking, cigarette smoking especially. Even passive exposure to smoking can induce the risk of COPD, or exposure to any other toxic chemical for the lung, like air pollution and fine dust. So these are factors that endogenous factors are factors you might be exposed to, whether willingly or not willingly. And then there are genetic factors. For example, a deficiency of alpha-1 antitrypsin. A deficiency in this specific protein can often lead to destruction of the lung, and we will come as to why in a few minutes. There's also Cartigner syndrome. If you recall, Cartigner syndrome is a condition in which you can have bronchiectasis, you can have recurrent infection, sinusitis, for example, and you can have situs inversus, where most of the organs, they are on the opposite side. So for example, the liver would be on the right side, the heart would be on the right side as well, dextrocardia, for example, all because there is a dysmotility in the cilia itself, the hairbrush. There's also other risk factors like premature birth and recurrent infections for COPD. Now, of course, this is a histopathology slide from a damaged alveoli or terminal bronchiole of the lung, showcasing portions of the alveoli that are damaged. So if you look at the right side, we have a couple of normal alveoli composed of air. But if you look at the left side in comparison, you can see that there's destruction of the alveolar air sac, with the spaces, these white spaces, they are enlarged. So this is indicative of COPD. When there's destruction of alveolar air sacs where the spaces are enlarged. So you can compare the left side with the right side, all right? And why does this occur? Because there's chronic airway inflammation accompanied with lung tissue destruction. Of course, a lot of the airway inflammation, why does it occur, is because most commonly there's exposure to a toxic chemical, such as cigar smoking. And because it's a toxic chemical, it will induce an immune response. So inflammatory cells. And what does inflammatory cells of our immune system release in their response to smoking? They will release cytokines. So cytokines such as growth factor, tumor growth factor, or interleukin 1 and 6 and 10. We're talking about pro-inflammatory cytokines that can induce inflammation as well as induction of structural changes of the lung parenchyma. So all this because we have inflammatory cells like neutrophils, macrophages, and CD8 T lymphocytes releasing their inflammatory cytokines in response to a toxic chemical such as cigarette smoking. So the question comes, what does tumor growth factor do specifically? Well, tumor growth factor unfortunately can promote healing with fibrosis. So essentially it can stimulate fibroblasts. Fibroblasts deposit their collagen, and collagen goes on to promote fibrosis in the lung parenchyma, and that leads to narrowing of the airway, and thus we have an obstructive lung disease in the form of COPD. What about other inflammatory cytokines like interleukin 1, 10, and histamine? What do they do to the goblet cells, which secrete mucus? Well, they stimulate or they cause an increase of the number of goblet cells. So you have increased mucus secretion, again contributing to obstructive lung disease. And what do they do to the smooth muscle of the bronchioles and pulmonary blood vessels? They hypertrophy, or they undergo hyperplasia or vasoconstriction, and therefore COPD can cause pulmonary hypertension, and pulmonary hypertension can often lead to right ventricular hypertrophy. And if that's the case, you run into the risk of CO, or let's say cor pulmonale. All right, so COPD is associated with cor pulmonale. Any chronic respiratory disease can often lead to the increased risk of cor pulmonale. All right, so these are many of the questions that we can answer one by one, and these questions, they are important to answer because they will explain the symptoms of COPD. Like for example, emphysema, which we now know is a severe case of COPD, where there's narrowing of the airway and obliteration of the alveoli. And we now know why people with COPD, they present with chronic productive cough as well as dyspnea. And we now know why pulmonary hypertension and cor pulmonale occurs on COPD. So this is just for explanation of the symptoms. And when we come to the tissue destruction as to why COPD occurs, tissue destruction occurs because smoking stimulates a specific, or not, it doesn't stimulate, or it does stimulate chronic inflammation, but in addition, it inhibits a specific protease inhibitor in our lung. Protease is an enzyme that breaks down protein. That protein in our lung is elastin. So cigarette smoking can inhibit an inhibitor, which is protease. And what is that inhibitor? Which is what we said from before. That inhibitor is alpha-1 antitrypsin. We talked about it in deficiency. Well, it can occur in a case of cigarette smoking, acquired cause. So, with inflammation increases the number of protease, which means it can break down the number of elastin in our lungs, and that leads to decreased elastic recoil. That means that expiration there's no full expiration, there's no passive expiration as well as it used to, all right? So when you smoke cigarette, it inactivates alpha-1 antitrypsin. Without alpha-1 antitrypsin, there is no inhibition of the function of elastase, an example of protease. So if elastase is uninhibited, it's not inhibited, this will lead to loss of elastic tissue and lung parenchyma via destruction of the alveolar walls. So this is important to know. So here we have a picture of a normal alveoli and bronchiole, and here we have an abnormal bronchiole. So you can notice how in this one, the airway is supported by the connective tissue and there's elastic recoil. But in COPD, there is destruction of the alveolar air sac. So there's enlarged air spaces as well as loss of support leading to airway collapse. And that leads to the trapping of CO2 in the lung. You know, carbon dioxide will be trapped in the lung in case of COPD. Why? Because remember, decreased elastic recoil. We're trying to do expiration. If we're not able to do full expiration, but that means that carbon dioxide will be still in the blood. It will be trapped in the blood, known as hypercapnia. And that will lead to hypoxemia because we have carbon dioxide and not oxygen. So we'll have deoxygenated blood. So we'll have hypoxemia and hypercapnia because of increased ventilation and perfusion mismatch. The ventilation, it is low. The lung is affected, but the blood vessel, the perfusion, it is fine. So we have a mismatch, and that leads to hypoxemia and hypercapnia. All right, this is what occurs in COPD, or more specifically emphysema. All right. So now we know the signs and the symptoms we expect from COPD. Why a patient may come with dyspnea or tachypnea or chronic productive cough or pursed lip breathing, which is a compensatory response to a lack of expiration. Pursed lip breathing is a way for the patient to inspire air through his nose and expire air through his lips, like a whistling. He pretty much tries to exhale the air through whistling. This is in order to get the oxygen in as much as you can and be able to get rid of the carbon dioxide out as much as you can. And this is a characteristic feature of COPD, severe cases. And also cyanosis, because remember, hypoxemia. And on auscultation, you might hear wheezing, crackles, muffled heart sound. On examination, you might see a barrel chest due to increased AP diameter. Again, the lung, it's not doing full expiration. So you might have, with destruction of the lung parenchyma as well, you might have a barrel chest deformity. All right. Hyperresonant lung, again, composed of carbon dioxide, which is air. Right ventricular hypertrophy and signs of cor pulmonale, for example. And patient might be cachexic, very skinny. Patient may come with COPD in a case of nail clubbing, which is an indicative of hypoxemia. So all of these are signs and symptoms of COPD. And of course, there's some differences between pink puffer and blue bloater. When you hear the term pink puffer, which is basically your lips being pink due to pursed lip breathing, this is associated with COPD and not chronic bronchitis, which is associated with blue bloater. So here it's giving you the differences between the two in terms of mechanism, in terms of clinical features, and also in terms of partial pressure of oxygen, which is low in COPD, while CO2 could be normal or high in case of COPD. And this is the opposite in, or almost the opposite in, blue bloater, all right? Which is chronic bronchitis. So now we can summarize what will be the typical case in SMLE. It will show in a case of COPD, a 40-plus-year-old male who is a chain smoker who presents with chronic shortness of breath and productive cough. Now, when you hear this case or when you read this case, you want to differ this case, or you want to differ COPD from asthma. How can I differ COPD from asthma in just this question? From the age. So if you look at the patient's age, he is 40 plus years old. In the case of asthma, it is a young people, it's a young person. What about the type of cough in asthma? It's a non-productive cough. Well, here's productive. What about history of atopy, allergy history? This is an asthma and not likely to be in COPD. What about in spirometry? In spirometry, you might see the same FEV1/FVC ratio. They're both the same. They're both obstructive lung disease. So the ratio might be less than 70%. However, if you give the patient bronchodilator and you assess the FEV1, if it improved by 12%, this is asthma, because asthma, it is a reversible condition. There's bronchoconstriction, there is obstruction, but it is reversible. So if you give a bronchodilator, the patient's symptoms will improve. But if you give the patient a bronchodilator, in a case of COPD, it will not reverse the symptoms. So the FEV1 ratio will still be intact. That is the biggest difference between asthma and COPD. One is reversible, the other is irreversible. And you can prove that by giving the patient a bronchodilator, as well as assessing diffusion lung capacity, for example. So this is how you differ asthma from the question from COPD. And this is a table showcasing the difference between asthma and COPD. They're both the same, but you can take the difference, or you can assess the difference through DLCO, diffusion lung capacity. It is normal or high in asthma because the lung parenchyma, it is reversible. There's no long-lasting damage. But in COPD, with destruction of the alveoli, it could be normal or high, Another difference, as we said, when you give the patient bronchodilator, this ratio could be less than 70%, regardless in COPD. Or the FEV1, it improved by 12% or more in asthma when you give a bronchodilator, but it's the same in COPD. So, of course, there are other investigations, but the most important ones are clinical history and spirometry, all right, or pulmonary function test, spirometry and bronchodilator improvement test, okay? There are other investigations like arterial blood gas showing respiratory acidosis, indicative of hypercapnia, other parameters indicative of air trapping. You can assess the serum alpha-1 antitrypsin level if you're suspecting deficiency. And then you have imaging. Now, please keep in mind when we look at imaging for COPD, it's not for the diagnosis. We're not to diagnose COPD. We are to exclude differential diagnosis of COPD, all right? But now we want to test ourselves. So if a patient comes with chronic shortness of breath, what's your likely diagnosis from a PHS X-ray? This is emphysema. You have hyperinflated lungs. They're mostly composed of air. And you can see flattening of the diaphragm. It is flat. It's not dome-shaped in appearance. So now we can apply the findings of COPD on X-ray or even on CT. But remember, imaging is not for diagnosis. It's to exclude differential diagnosis of COPD. All right? All right. And of course, this is the summary. The differences between asthma and COPD in terms of age, etiology, presentation, obstruction, and now we will come to the biggest difference between the two, which is medication. So the treatment for COPD will slightly differ from asthma. You might see the same medications, but how they're used is completely different. Now, when it comes to treatment of COPD, you have supportive, medication, and oxygen therapy, which is SOM, S-O-M. Let's start with supportive therapy, which is the initial first line. So if a patient is typically a chain smoker, you tell this patient to stop smoking. And if the patient is not vaccinated, tell the patient to be vaccinated against influenza and Streptococcus pneumoniae, because they found by stopping smoking and doing vaccination, they improved the survival among COPD patients. They reduced the mortality rate among COPD patients. So this is very important to know. Which of the following improved the survival rate of patients with COPD? Smoking cessation, vaccination, and the third point is oxygen therapy, which we will come to shortly. Besides supportive therapy, you have medication therapy. What is the key principle to know? You need to know that bronchodilators, they are the mainstay of treatment in COPD. Why? Because this is an obstructive lung disease. So we might use a bronchodilator agonist, all right? We might use a LABA or a SABA. We might use an antimuscarinic, a LAMA, a long-acting, or a SAMA, a short-acting. So we might use one of them. We might use both of them, according whether or not it's acute versus chronic, and according to the severity, all right? In addition, we may use inhaled steroids in combination with LABA or with SABA or whatever, according to the case, all right? You should know we might use bronchodilators and we might add to it inhaled steroids. In summary, you need to know this. In a case of chronic COPD, in a case of follow-up, we can use LABA and or LAMA and or let's say and inhaled corticosteroid. We can use these three medications, especially inhaled corticosteroid, according to the eosinophil count. That is specifically for inhaled corticosteroid. In a case of acute exacerbation of COPD, we might start with SABA or SAMA, short-acting beta agonist or short-acting antimuscarinic agonist, all right, in an acute case. If this doesn't work, if the medication for acute exacerbation doesn't work, we might do ventilation, and we'll come to it shortly. So, of course, this is the initial pharmacological treatment of stable COPD. So we can start here one by one. So initially, in a case of mild COPD, the first step is to start with either LABA or LAMA. So this is in a case of stable COPD, not an exacerbation, okay? So step number one, let's start with either LABA, salmeterol, or LAMA, which is tiotropium, not ipratropium, which is a short-acting one, okay? We'll start with either one. If step 1, if that didn't occur, we will use both of them in combination, which is called group B. So we will initially start with either LABA or LAMA. If it didn't work, we'll use them in combination. If the combination therapy did not work, we will use inhaled corticosteroid, like fluticasone, for example. Or if the patient is eosinophilia, if his eosinophil count is more than 300, we might add inhaled corticosteroid. So inhaled corticosteroid can be used in combination in case of eosinophilia, more than 300 cell count, or if step number 2 did not work. And what about in exacerbation of COPD? We might use SABA or SAMA, ipratropium or albuterol, for immediate relief of dyspnea. If this didn't occur, if we have a specific indication, we might instead use ventilation in exacerbation. So this is again a summary from the tables. You can pause the video and summarize for yourself. So to summarize the indications to add inhaled corticosteroid for COPD, if there is an overlap between COPD and asthma, you might use inhaled corticosteroid. That means the symptoms. If he has eosinophilia, and if the symptoms continue despite combined therapy. And here is obviously the summary of COPD guidelines. You start with supportive therapy. Then you might start with, if in a case of exacerbation, SABAs or LAMAs, or SABAs or SAMAs. You can use LAMAs or, long-acting beta agonists in a case of stable COPD. And of course, you might add inhaled corticosteroid, and you might use oxygen and surgery, all according to the case, step by step, all right? Now, of course, we come to the last part of the video, which is oxygen therapy. Now, oxygen therapy, which is the last part of COPD, this oxygen therapy, when given to the patient via a ventouse bag, it is given under a specific criteria. The partial pressure of oxygen has to be less than 55 millimeter mercury for the patient to be receiving oxygen therapy, or the oxygen saturation has to be less than 88% at rest. So the patient, we will give him oxygen if he is hypoxemic, if the partial pressure is less than 55 or the oxygen saturation is less than 88%. And they found that oxygen therapy increases the survival in patients with COPD. All right. Of course, there are surgical options. You can do surgery for the patient if he has severe emphysema. You can do bulectomy. And if he has a case of severe COPD, but he can't do bulectomy, you might do, as a very last case scenario, lung transplantation. All right. So you can remember the surgical options, but the most important thing is to remember the indication of oxygen therapy. Less than 55 and partial, less than 88 in oxygen saturation. So, of course, here's the summary. The things that improve survival in COPD: smoking cessation, vaccination, home oxygen therapy. The indications for home oxygen therapy is the partial oxygen less than 55 or the saturation less than 88%. Another information you should add is that we need to get 2 readings. So we need 2 readings at rest, not during exacerbation, no, at rest, out of attack time. So if we have 2 readings of hypoxemia less than 55 or less than 88% for saturation, we will give the patient home oxygen therapy. All right, that is the main indication. You need to remember that 2 readings. There are other indications as well, like nocturnal hypoxemia or the oxygen on partial pressure being more than 55 if he has pulmonary hypertension. So these are other causes as well. This is from Jamiat Al-Qura, by the way. So now we come to the very final part of COPD, and now is that when do we do ventilation? As we know, we have non-invasive and invasive ventilation. Of course, non-invasive BiPAP and CPAP, they are much better than invasive because they are non-invasive. That is more convenient for the patient. It's very simple. So if a patient has a case of acute exacerbation of COPD and he is hypoxemic, then this is an indication to have the patient undergo ventilation. We will give the patient oxygen in the form of mechanical ventilation, all right? If the patient is conscious and alert, we will give him non-invasive mechanical ventilation, BiPAP and CPAP in a case of COPD exacerbation with hypoxemia, all right? But if the patient is at increased risk of aspiration, so let's say the patient is comatose, or he has altered mental status, or he has stroke, or he's under anesthesia, or his mouth is full of secretion. If he is at risk of aspiration, then I cannot have the patient undergo non-invasive mechanical ventilation. No, I will have the patient undergo invasive mechanical ventilation. And regardless of the type of ventilation, regardless of the type, I will give him 2 liters of oxygen at least. 2 to 4 liters. And when I'm giving the patient oxygen, my target for oxygen saturation, my target in a COPD patient with CO2 retention, my target for oxygen saturation when giving the patient oxygen through ventilation, the oxygen saturation should be between 88% to 92%. It should not be more than 92%. Now you might ask yourself a question. Nawaf, 92%, this is a case of hypoxemia. Why should we keep the oxygen saturation between 88 to 92%? Well, the answer is simple. The answer is because in a patient with COPD who has chronic CO2 retention, he is used to a very specific level of oxygen. What do I mean by that? I mean that when a patient has COPD, he will have high levels of carbon dioxide, right? Chronic CO2 retention. He'll have high levels of CO2. And when you have high levels of CO2, it will decrease the pH. He will have respiratory acidosis, right? Now, because you have decreased pH, this will depress the respiratory center in the brain. The respiratory center in the brain will be depressed. It will say that, okay, I have carbon dioxide at this level. I have my pH at this level. So my oxygen demand is low. It is not going to be super high. I am so hungry for oxygen that in order to conserve energy, I will have oxygen level at a specific criteria, at a specific parameter, at a specific level. Okay? So to save itself, I'm going to have oxygen at a lower rate. I'm going to adapt myself at a lower oxygen saturation. That is the thinking. That is the rationale of the respiratory center in response to respiratory acidosis in COPD. So what happens if you give the patient oxygen and the oxygen was more than 92%? The patient will have respiratory arrest. This patient will have so many oxygen. He'll have so many oxygen in his body. And you know what his respiratory center will do? The respiratory center, which was used to low number of oxygen as compensation, you know what it will do? It will cause depression. It will cause negative feedback. The respiratory center will be inhibited. And if it's inhibited, you will have respiratory arrest. All right? So please, when giving the patient oxygen through mechanical ventilation, your target for oxygen saturation in a COPD patient is between 88% to 92%. Which ventilation? If the patient is conscious and alert, BiPAP and CPAP. If he's not, if he's at increased risk of aspiration, we'll do invasive mechanical ventilation. All right? That is pretty much it. And of course, as you know, COPD has something to do with cardiovascular system, which is pulmonary hypertension and cor pulmonale. So you diagnose cor pulmonale or pulmonary hypertension or right-sided heart failure via echocardiography. So any COPD patient coming to you with signs and symptoms of cor pulmonale, the next investigation is echocardiography. All right? If a COPD patient comes to you with an irregular pulse, so let's say an irregular pulse in which on ECG shows a supraventricular tachycardia, this is multifocal atrial tachycardia, which is a type of supraventricular tachyarrhythmia with an irregular pulse. How do you treat it? So through an antiarrhythmic. You give the patient antiarrhythmic and treat the underlying cause. So any COPD patient with an irregular pulse or ECG finding of MAT, treat the patient with antiarrhythmic and treat the underlying cause, which is COPD. That's pretty much it for COPD. And on the next video, we will revise together the COPD flashcards, and or not necessarily the COPD flashcards. You can revise it at any time. Thank you for listening.